and Rajiv Gandhi Cancer Hospital. This is my second instance that I've come to address this audience, and really very satisfying. Having said that, I can really feel what my previous speaker was feeling, because I went through this, and we used to call it bone marrow transplant in the good old days. And that was something that was utopian, and that is why we never thought that we could gain entry, because those centers are really specialized centers, and really you have to don gowns and mask and everything. And the entire area was HEPA filtered, and ultrasound, I mean, sorry, UV radiation was done. And that is why it was difficult for us to even fathom going it. But I was really impressed by what Dominic said, Dr. Raymond said just now, that we need to have that CAR T cell mnemonic, even for the stem cell transplant, as we call them now. We should be involved in it right from the very beginning, and there should be somebody dedicated to that in it. Having said that, the brief that is given to me is to speak upon approach to infections in stem cell recipients. And I must congratulate my hematologist colleagues that what used to be relatively common in the good old days, that quite a few of these patients would end up in the intensive care unit. Nowadays, we hardly get to see it. It's almost like having an operation theater upstairs in our hospital, where around 120 cases are done, but in a year or we get one or two patients who come to us from the operation theater. I think the same thing is going replicated in the stem cell therapy also. And I think the learning curve has been crossed, and they have become more proficient in doing this stem cell transplant in the centers. So just for the beginners and the people who are not necessarily hematologists, and a lot of people would be here, they would not understand the real meaning. I mean, these are the various types of transplant. It could be allogenic and autologous, and I think a lot of people before me have spoken about what is the type of transplants that are done, and the source of the stem cells. They come from bone marrow, peripheral blood, or cord blood. Cord blood has really become outdated now. It's mostly from the peripheral blood that we take it. But what we need to really know is that even before the actual procedure of stem cell transplant, quite a lot of people, because of the basic disease, could have a lot of complications already present. Mucositis is almost a universal phenomenon in these patients, and there could be pre-existing infections. We might have treated them, but it is one thing to say that we have treated them, one thing to say that they are asymptomatic, and an entirely different thing to say that this infection has been eradicated. So these things are there, and of course, the complications which are related to the transplant itself, they are going to be there. So at the end of the day, if the patient is being suspected of having infection, and that was a question my chairperson asked just now, as to how to differentiate, and that I'll answer to it in the due course of time. But when I am thinking, I'm referred to is when the patient is having some serious complication which needs intensive care. That means a life support system to be added to that patient's. So there my approach will be dependent upon my estimate. Now let me tell you very clearly, it is an estimate. Maybe the older I become, my estimate might become more closer to reality, more closer to the truth than what I was probably 5 or 6 years back. So the net state of immunosuppression that the patient is having, that is a guess estimate that I have to make when I am dealing with this kind of patients. And the most important contribution, in my opinion, would be the state of organ function. I had a fight with a liver transplant surgeon 20, 25 years ago when we started liver transplant program in our hospital. I told him, give me an organ which works and then tell me to treat the sepsis. So that is the answer to your question. The question is, the patient is generally, sepsis is a wonderful dustbin to put all the problems into, because it can explain everything. But at the end of the day, if you treat sepsis, or if you are approaching the patient as though he's having some infection, you would probably win the battle. But you're not going to win the war unless you have an organ which is functioning. And in this case, we are talking about the stem cells, which are able to change the course and the outcome of the disease. So what we go by is, as I told you, beforehand, when the patient has had the engraftment, we need to know how much of mucositis does he have, what kind of organ failure does he have, what kind of environment has been exposed to, what kind of community acquired infections that he might have had in the previous occasions. But more importantly, as we really work up these patients, is the presence or even IgG or IgM of something like cytomegalovirus. Now, if I were to give you a very simple example, now, if my net state of immunosuppression is, let us say, I give a figure of 100, and this patient tests positive for CMV, his net state of immunosuppression is going to become 150. So that is the kind of area that we are working at. So there are so many immunomodulating viruses which get reactivated almost immediately after the engraftment, and they may change the course of the disease, they may change the presentation, they might look what could be a complication of stem cell therapy into a florid sepsis. Of course, there are other factors, metabolic factors. Almost invariably, graft versus host disease is one thing which is likely to happen. You might have undergone chemo or radiation therapy, and most importantly, as Raymond just now said, people are having age of 60 years on an average. Median age is around 60 years. They are very likely to have an underlying disease, and in India, one out of every two patients would have a diabetes. So all these factors have to be taken into account when you are guess estimating the net state of immunosuppression that the patient is likely to have. So, what happens when we do this graft infusion in this patient, in stem cell therapy? The immunocompetent cells, the ones which are supposed to be fighting the infections or destroying it or engulfing it or opsonizing it, whatever you call it, they take weeks and weeks to months to recover. And this is the period when they are very vulnerable. But then there are a lot of people in different fora where people are on the as the chairpersons were pure hematologists, and they would say that no, in our case it doesn't happen. I mean, we have this immunosuppression, neutropenia, and all that stuff for 5 days, and after 5 days things become all right. I don't know. I'm not too sure about that because I would believe that the net state of immunosuppression doesn't come back to normal until 3 weeks or 3 months are over. So that is something that we need to be aware of. So in general, we tend to divide the engraftment period into a pre-engraftment period in which these are the problems which might the patient might be having, which they deal with pretty well. And obviously, once that immediate post-engraftment period, 3 weeks to 3 months, again the mucositis is a decrease in cell-mediated immunity, reactivation of these immunomodulating viruses, hyposplenism, and obviously the inability to opsonize bacteria and other so-called virulent organisms. That is an area where I think, as he Damon mentioned just now, if you use that mnemonic of CAR T cell and involve an intensive care person right from the beginning. And I'll come to that again later on in the course of my lecture as to how that would benefit the patients in general. And obviously, this is the late post engraftment, even after 3 months, we still have immunodeficiency. So we are dealing with an immune deficient patients. So what is the timeline of infections? The timeline of infection just in the beginning. In the beginning, generally it is the reactivation of viruses. These viruses are there. Herpes virus is lurking in the neural tissue of your body, and you have a common cold and you get rashes around your nose or the angle of mouth. So these are the viruses which are there, which are almost like symbiotic, having a symbiotic relationship, and they get reactivated when there is a sudden decrease in a sudden increase in the immunodeficiency. What happens after that? This is for the first week, maybe second week to third week, maybe you have the common thing that I told you just now, the presence of cytomegalovirus. Now, it could be both. It could be cytomegalovirus virus. They might have got it from the donor, which was probably not detected, or maybe the titer of the SFCMV was so less that it was not detected, and that got reactivated in the post-engraftment period. So cytomegalovirus comes later on. Nowadays, we talk about BK virus and EB virus. Even they are coming up and showing up their presence. But these are the things that we occur in the second phase after the first 7 to 10 days are over. In the second phase, up to almost 1.5 months, these are the viruses which are more common, and that is why your suspicion should be towards detecting these. Now, we can have a huge discussion about how to really diagnose these viruses. Very, very difficult sometimes, and very few centers actually do it. But then what happens is the possibility of fungal infections. Now, candida infections are almost like a community acquired infections nowadays. So they can be present in the first phase of the illness. But mold infection, which is what we are worried about, and all these hematologists generally treat the patient prophylactically for mold infections, for PCP pneumonia, for viruses, cytomegalovirus, for example. So again, the next set of immunosuppression would depend upon what kind of prophylactic therapy these patients have got. So these are the things, and that's why encapsulated bacteria generally come in late after 3 months. And after 3 months, we have varicella zoster. Now, there's a bit of a theoretical gap as to why varicella zoster should come in so late. But then we are not surprised. In the intensive care, we tend to get varicella zoster in patients who are 70 years old, 80 years old, and it's just due to senescence of the body. And probably that similar kind of picture is coming in the third month of post stem cell transplant. And the same, perhaps the same reason is why we get pneumocystis carinii or pneumocystis cerevisiae infections after that. Even otherwise, the ID specialist, he would tell you that pneumocystis carinii infection after transplant, for example, do not happen immediately. They generally have a very torrid course for a period of 1 year. They come and get admitted for suspected rejection. They are treated with high dose of immunosuppression. They are given pulse methylprednisolone, maybe a lot of other therapies that go along with it, even plasma exchange and all that stuff. They tend to be suppressed, sent back home, but they come back again. And this time, when they come after almost 1 year, they come with an hypoxic respiratory failure. Really don't need to be a rocket scientist to know that this patient is suffering from pneumocystis cerevisiae pneumonia, despite the fact that we have a center which is probably now universally accepting PCP prophylaxis in all our patients. And I'm sure even for the stem cell transplant, they're doing it. So obviously, I mean, there are so many reasons why these patients could get these kinds of infection that it is superfluous for me to talk about what are the risk factors. Obviously, in the recipient, older age and advanced comorbidities, those are there. And then, obviously, after the transplant has been done, the complications of the transplant are also likely to happen. The more number you do, the more chances of complications are there. And then there is a technical aspect, and this is where perhaps we have made a huge success, a huge advancement. The transplant related, the procedure related complications have come down significantly. And perhaps that is the reason why people, full time intensivists like me, do not find too much of interest in stem cell transplant in our centers. So I talked about prophylaxis, and that is what I'm trying to say, that till 6 months, septran prophylaxis is given. But I would always caution you that as long as immunosuppression is going on, or as long as you think your net state of immunosuppression is that much, is something like CD4 count in HIV patients or PLHA patients, as long as you think that the net state of suppression is below a threshold, carry on giving Septran prophylaxis. Until neutrophil recovery, an antifungal prophylaxis is also advisable. Now, the classical antifungal prophylaxis used to be fluconazole, grade 1 recommendation, but that is subsequently moving on to posaconazole prophylaxis, especially after the gastro-resistant tablets that have come into the market. They are working equally well. But in graft versus host disease, I'm afraid you don't have a choice. You tend to give posaconazole, and I would not recommend giving voriconazole patients. All transplant patients, voriconazole is something that I am very loath to prescribe because of the toxicity to the liver, number one, and number two, the various drug interaction that these patients have, and the inability of our centers to actually measure voriconazole levels, serum and serum levels. So, what is the cumulative incidence of fungal infections? And if you can see from clearly from the graph that among the allogenic recipients, the infection is obviously much higher, almost 5 times or 6 times higher than the autologous transplants. Not surprising, but in allogenic transplants, the infection becomes exponentially higher, especially around 6 months after the transplant has taken place. So after 6 months of the transplant, I told you after 1 year probably you think of PCP. After 6 months, you're probably thinking of a fungal infection. Now, the question is, what do you do if you are thinking about that? So, just to illustrate a point, and this fungal infection could be anything. I told you just now that aspergillus and candida was the only two things that I told you. But in this patient, I'll show you that it can be anything under the sun, which something probably you might have heard for the first time. 38-year-old myelodysplastic, refractory anemia, mud transplant day 517, medullary and extramedullary disease which has relapsed on intensive chemotherapy, prolonged neutropenia and fever, developed skin lesion for at least 1 week. Now, believe me, I mean, it could be really anything. And this is the kind of lesions. Anybody wants to have a wild guess? There are some hematologists there. You could be right. But yes, we move on. We move on. This is obviously a neutropenic patient. And obviously, we would do a biomarker. And would histoplasmosis show galactomannan positive, ma'am? No, no, okay. But would galactomannan be positive in histoplasmosis? Unlikely. Unlikely. So we are dealing with a condition which is producing a generalized immunosuppression. Galactomannan patient in you, me, and usual community acquired infections, galactomannan is devoured by the active neutrophils in your body. So it is not even recommended. Serum galactomannan is not even recommended. Perhaps you can make a case for bal galactomannan, but serum never. Serum never. Serum never. You will never get serum positive. Here, because the patient is neutrophil depleted, you are getting a galactomannan positive. So now we are thinking about those conditions where galactomannan is likely to be positive. It's not giving me any information. These X-rays. I wish I was in the COVID era and I would have safely said that this is COVID and let us treat it as COVID. But it could be anything. There are some ground glassing appearances, that's all, but it's not really very specific. So what do? We ask the ID person to come in and listen what he makes. He makes a diagnosis either a fungal infection or it could be a gram negative, which are multi-drug resistant bacteria. That doesn't help me too much. But anyway, that is what they say. So what do we do get as results? We do a skin biopsy, and I'm telling you, when the skin biopsy report came, that English I could not understand. So I went on my something which I depend upon is my cultures. And the cultures from both the skin lesions and blood culture were fusarium. Now, this is not a fungus which we commonly come across. But that is the reason for illustrating this case was this kind of things can happen. You can get almost anything and everything when you're dealing with suspected infections in this kind of care. So what are the critical care considerations? Some small things that I, like a teacher, I would like to teach my students or my residents in the intensive care. They should know what is a fever and they should know what is neutropenia. Now, fever is anything more than 100 degree Fahrenheit. Neutropenia is anything less than 500 neutrophils in the cells. That is something they should be very clear about. And when you are dealing with a situation of this kind, the patient has come to you for a neutropenic fever, be a decider. Shoot first, ask question letters. Hematology is one area where you are licensed to give anything and everything under the sun. You start with broad spectrum antibiotics, you give antifungals, you give Septran, you give Jancyclovir, you will be pardoned. No questions asked. There are pediatricians who might say you shouldn't give this and you should not give that. But in adults, it is almost a license that you can give everything. Then work up the patient. Sometimes our documentations in the notes are so poor that you don't get the information. It's always better. Sometimes the relations of the patient know more about the disease and the patient's condition than what possibly the doctors know. Because they have been living. It is their life and blood. It is like their son or daughter or mother or father. Obviously, they know the minutest details when you start having watery diarrhea, for example. Those kind of things. So take a detailed history either from the patient if he is competent, or in the close relation. In case of husband, talk to his wife. In case of wife, talk to the husband, or maybe responsible children that they may have, and send all these investigations. So ask about all, try and send off investigations that you might get this kind of information back. The CD4 count, for example, whether the patient has received prophylaxis before the engraftment, is he still on prophylaxis? Has the patient traveled before the engraftment for some reason or the other, for family reasons? So all these things, chicken pox, sometimes you get this history of patient having chicken pox. So etiology can be anything. Polymicrobial infections are seen more commonly. You should have a very aggressive approach. Don't hesitate to take the risk to shift the patient for a CT scan. Coax and cajole your chest physicians to do a bronchoscopy in these patients, and if necessary, go for a biopsy. They can have hundreds of reasons, hundred of excuses not to do these things, but you can't afford it, and start with presumptive treatment. So, ladies and gentlemen, to end my talk, I have to tell you that this kind of therapy is limited by the high rate of severe complications, high rate of toxicity of conditioning regimen, immunosuppression, graft versus host disease. And when these patients come to me in the intensive care unit, it is difficult for me to decide whether the patient has come to me because of complications of the primary problem or the primary procedure, or is it because of secondary infection that the patient has acquired. The answer is really, I don't have the answer. The answer is says that I should treat the infection but not lose sight of the fact that this procedure has been done. So I have to direct my energies to, to treat the primary complications of the disease. So hematologist and I have to work in tandem to achieve the best possible result. He does his own work, I do, and maybe we can discuss that this is more likely. But rather than being antagonistic, we go hand in hand and treat the patient together, because most of the patients, if they happen to end up in complications, if they happen to go into organ support, they are very, very likely to die. And here becomes the most difficult part, where I was really wanting to have the intensivist there in the beginning of the therapy. The moment we talk to the relations, we are going to spell the doomsday prophecy to those patients. And these particular relations have been fed on an optimistic note by the hematologist. As he said, in CAR T cell therapy also, you have to be positive, otherwise you won't do it at all. So all the time, and even the hematologists encourage the relations of the patient to be optimistic and hope that the situation is going to get better in the next few days. Maybe we are going through a crisis. So there's a big dilemma. We are saying that the chances of survival are very poor, and the hematologists are saying that we have to fight. And the relations don't have a chance. They want the patient to survive at any cost. They know that the patient is suffering from a condition which required this procedure. So there comes a dilemma: how much and how. And they have been talking to the hematologist for the last 6 months, because he's undergoing therapy and the hematologist. And I come into the picture only 2 days prior to whatever it's the problem right now. And for us to say something as dramatic as the likelihood of D becomes very painful for the patient. And that is where I say that we need to be in the picture right from the very beginning. At least they will have faith upon us, if not anything else. And I really thank you so much for your patient listening.
Thank you, sir. It's a wonderful talk. Very difficult to speak about such a vast topic in 20 minutes. But any questions from the house? No questions. Sir, may I ask you a small question? Sir, how do you approach your antibiotic therapy in neutropenia? Like, if you get an opportunity, like obviously when the patient gets shifted from a transplant unit to ICU during the period of neutropenia, I understand that most of the time it happens is that you throw whatever possible scenarios are and probably give the highest amount antibiotic. My only question is whether how do you approach it? Whether you straight away start with the hospital, covering the all the possibilities, including CRO, VRE, everything, or do you look into the local scenario and then go
Yeah,
about
I
it?
mean, that is what I was coming to, because I'm a bit fortunate that we have local antibiograms. We are, I mean, you can look, they are in the public domain also right now. So we are a bit fortunate as to we know what are the common things happening in certain conditions. And these obviously become the high risk cases. And we have defined the high risk cases, and we have a fairly good idea what is the likelihood of organisms. And we have, at least even if we don't have the likelihood of organism, at least the ones that we can think of, we know their likely sensitivities or susceptibilities. So in those, that my job becomes easier, because my flora and fauna of the hospital tells me that I have to give this. I know fusarium is something which probably I wouldn't have thought of. I agree with that, but I have to do common things happen commonly. So I'll be dealing with those common things. So in the high risk cases, what are the usual cultures which are coming positive in the last 6 months? That is highlighted, and we generally go by that. And at the end of the day, you have to keep your eyes and ears open. Be prepared for some surprise to be thrown up at you, and it's very likely. I mean, we are coming across so many names which is very difficult for us to even pronounce when it comes to culture reports from the microbiology lab. And they say that these are generally um, not contaminants, but they are commensals. And if they are commensals, the question is that we have released the name, but we don't know whether you should be treating it or not. We leave that discretion to you. And it's difficult for us. And in situations of this kind, where I'm dealing with an immunodeficient patient, I would be inclined to treat the patient. and that is a big problem. That's a big something like an E. coli has come to me, which is only moderately sensitive to colistin, and in the blood they did not do fosomycin. Now this patient has clinically has got urinary tract infection. So if I'll be a fool not to use fosomycin in that patient, but the name is not there, and if the name is not there, the clinicians would say the name is not there, and you are bringing it out of your hat and trying to treat it. But the question is that penetration, whether the ability of the drug to reach the site of infection, that also has to be taken into account before we decide upon what to give. I hope that answers your question.